Hey everyone, how are you? So we're gonna go ahead and get started. We'll definitely jump right in. So this morning we will be looking at information gathering, the foundation of assessments and treatment planning. My name is Jessica Newton. I am a first year student in the doctoral program, Counselor Education and Supervision, of course, here at the Chicago School of Professional Psychology. And today, I hope that through this process, you all can have a different perception and a better, easier understanding of not only assessments, but the treatment planning, how we formulated diagnoses, and as well as looking at the DSM. So let's get started. Again, today we are going to look at understanding how to preserve the client's cultural background as we defend our DSM diagnosis. We're going to discuss the use of some evidence-based practices. We're also going to learn how to incorporate those interview skills, as well as I'm sorry, guys, as well as the review of the mental status exam and other assessments. So maintaining culture, we're going to look at the inclusion of cultural competency, and cultural competency is the foundation which can be met in awareness, asking for further understanding and offering unconditional positive regard. This is accepting of levels of importance of influence and the interruption of quality of life when we assess an individual and they express stressors or presenting problems. We are offered many different inventories, assessments, checklists to ensure that we are covering all bases. The diagnostic statistical manual, the DSM-5, offers a cultural checklist. And the checklist includes to allow for the person in the interview to describe their personal cultural identity. It is encouraged that we, as counselors, assess their severity of stress based on cultural constructs. That we identify their social stressors and social supports. We assess resiliency and perceived deficits. We explore differences between the person between ourselves as the counselor and the client. And then we summarize notable components that are relevant to treatment. So for me personally, I like to always look at how do we get from point A to point B, and what does that really look like? And that's something that, I felt was really important in this presentation. So if I engage with somebody and I go through that checklist that we previously listed, then this is the final result. This is what we want to formulate and actually see. So again, if I were to go back to this checklist, and I'm asking them to describe their cultural identity, describe the severity of stress, identify social stressors. What my end result and my documentation would appear as such as this. Client has described the cultural identity as American with no language barriers. And cultural identity, this is what the client presents as who and what ethnicity they identify with. Client has emphasized religious practices and importance of family. as well as or also sources of stressors. So if we just kind of look back at that, and we understand that the client has said that religion is important to them, as well as family. Family is important, but this is also a source of stress. So if we think about family dynamics, there can be so many stressors that can be identified there. We could have, just different roles that are played in the family that may present of, of a source of stress. So the next statement is client identified clergy as support, however, reluctant to disclose familial discord, reporting potential disgrace to family expectations. And so while that sentence seems really loaded, essentially this client is saying that my religious background and the clergymen at my place of worship, their support for me, but telling them telling them everything that's going on with my family, I may be hesitant because, understandably so, for somebody who understands the dynamics, of religion, then we we may be reluctant to tell everything, just because we look at these individuals with high regard and we respect them. So at times we may be hesitant to disclose everything. And so here the client is pretty much saying, I don't want to be seen as a disgrace. And so those direct quotations are something that was a word that was described by it was a word that was offered by the client to describe how they perceived should they expose this information. The final sentence says that client denied potential discomfort with the differences of race. So again, when we go back to this checklist and we're looking through, the client's words were the person identified as American. Severity of stress is based on culture, and so she identified one of her stressors. She identified religion as being important as well as family, but then also identified those also as stressors. And then the social supports were identified as the clergy. And the client reported no differences or no concerns, no notable concerns between the counselor and the client. And so why is this important? Why do we need to be sure that we cover the cultural competency or the cultural checklist? We want to avoid misdiagnosing. We want to obtain useful clinical information, build a rapport, engagement, efficacy, and efficacy, as a guide to research, as well as clarify concepts of distress. So, understanding where that person's culture lies and the level of importance allows us to get a better perspective, because if we could have one person on Monday who, holds clergymen in high regard, and then we could have a client on Wednesday and it is and religion does not weigh heavily in their life. So we really have to understand what is important to the person who is sitting in front of us as we engage in the in the therapeutic, well, as we engage in the clinical exchange of information. And so here again, we're really stressing the importance of gathering information and assessment, but also how do we take those questions and formulate them into our diagnoses as well as a treatment plan. So here, when we think about school in context, we have this word as we see this word conceptualization. And so within the conceptualization, that is what what are the factors and the things that are important to from the interview to from the interview to the composition of the assessment itself, and then ultimately to the treatment for the client. Here we have, not only does Drummond mention that presenting problems, background information, and experiences are relevant to diagnosing, but there are other areas that we want to be sure that we cover, that we could potentially cover or incorporate in our clinical process, to ensure that we are hitting important areas. And so those are, again, the presenting concerns. What is it that is important to the client? In terms of stages of change, where is the client in their readiness to move forward towards their goals? Not the goals that the counselor believes, but the goals that the client wants to achieve. Viewing Maslow's hierarchy of needs, where is the person today? Do they embrace this humanistic perspective? And if they do, then what is it going to take for them to reach self-actualization? What are some of the resiliency factors? What are the things that allow them to bounce back and push through? And what are some of the barriers to treatment? Barriers to treatment may include transportation. Barriers of treatment may include childcare. Barriers of treatment may include um, no no televisits, no telebehavioral health. If I don't have access or even access to the internet, to engage in telebehavioral health or some type of distant mental health counseling. And the final thing is crisis prevention. What is it that may exacerbate or worsen the person's the person's current status, their person's current mental and emotional state? We want to be, mindful of that as well. So the next thing is we have to defend it. We gather this information, we put it together, and then we create we line up what we believe is a potential diagnosis. Well, we need to defend that diagnosis. And so when we look at the incorporation of the clinical assessment, that overall process, the goal is to diagnose a mental health disorder, develop a plan of interventions, monitor the progress, and evaluate the outcomes. So we have this interview, we gather the data, we organize the data, we integrate it, we incorporate our clinical judgment, we give our opinion of the DSM diagnosis, and then we defend that diagnosis. So we had this, somewhat of an equation here, but what does that look like? That looks like we conduct an interview. That's when we engage in a conversation and we gather what are the concerns in the person's everyday life and what are the concerns that are that have been increased stressors. We arrange that information. In most cases, in a situation where insurance is involved, we would arrange that information in accordance to a biopsychosocial assessment, which does look at the biological factors, the psychological factors, and the social factors in the person's life. We illuminate the information that is influencing the person's quality of life. What is it that, again, is the presenting concerns? What is it that is a barrier for them to live a more fulfilled life? Next, we would explain the evidence of the DSM diagnosis, and then we offer treatment recommendations. So once we have additional items out there in the realm of assessment that help us support, that provide additional support to the diagnosis that we've come up with. And so the DSM-5, in the back of the DSM-5, you'll see the page numbers here on page 752. There's the cultural formulation interview, the cultural formulation interview, which we can conduct to ensure that we are covering all cultural competencies. There are other assessments that are listed in the back of the DSM-5, page 734. There are additional assessments. And then throughout coursework, we have heard of additional inventories such as the Beck Depression Inventory, the Beck Anxiety Inventory. The list goes on. There are endless numbers of assessments or inventories, but this information provides support to what we as counselors and clinicians have formulated as the potential. And so this would be supporting evidence of what we have seen, what we have, what we've heard, what we've observed, and then what we have documented. And then the diagnosis code that, the diagnosis or the mental health disorder that we have assigned. So if we do see signs of anxiety and we, after conducting that interview, then we can follow up with a Beck Anxiety Inventory as additional support to what we have already identified. We could also do the same, if depression was involved. There are a number of, well, again, endless numbers of additional assessments and inventories that can be used to support a diagnosis. And again, there are more listed in the DSM-5, in the back of the DSM-5. So when we're looking at the DSM, we have this huge like encyclopedia with phone books over large. It's just, sometimes it can just be like so overwhelming. How are we supposed to break that down? Well, for me, and there have been others that have offered a breakdown of or an easier way of assessing a diagnosis. For me, it has been to look at what are the immediate presenting concerns. Is this a mood concern? Is this a stress concern? Or is there psychosis involved, substance use, or organic brain disorder, neurocognitive functioning deficits? That's the first thing that I want to, I kind of want to look at or keep in mind, when I'm conducting an interview. Did they say anxiety? Or did they say that, they were depressed? Did they say that they were seeing or hearing things that others didn't see? Did they mention the use of a substance? And once we take, I believe that once we take the anxiety or the overwhelming feelings associated with that big DSM, and we just kind of break it down, it will definitely help us, and we'll be able to guide easier to the ultimately to a mental health diagnosis. So again, my first thing is, or for me, I like to keep in mind what is it that is reoccurring? What is it that is interrupting their daily functioning? And what are those symptoms that we're hearing? So if we heard reports of a neurocognitive, then we would start to look at some of the diagnoses that are associated there. So here we have, and this is actually an older chart here, but this is really looking at delirium and the different factors that would be involved. And so if we are able to identify that it is a neurocognitive, concern, then we can start to move to those particular areas of the DSM and gain more detail. So I'm sorry, guys. We have, we've went with delirium and then dementia. And so I'm not going to go through each diagnosis, But of course, you know, this information will be available to you guys once the conference is done. But I would like to look at some of the more illuminating questions. So when we're looking at anxiety, a lot of times mood disorders, and a lot of times mood disorders, we first want to ask, is there any medical condition related, or a physiological experience that's related? And so when we are looking at specifically at anxiety, then we may have um, a medical anxiety. Excuse me. We may have anxiety induced by a medical condition. We may have someone who has a panic disorder. And there may be somebody that has a I'm sorry, anxiety, a substance use anxiety, a substance induced anxiety disorder. I apologize, guys. And if there are no medical conditions that are involved here, then can the source of anxiety be identified? What is it that's bringing on that anxiety? And if we're not able to, then we have 3 diagnoses that allow us some flexibility, which is general anxiety disorder, other anxiety disorder, or unspecified anxiety disorder. But if we are able to to dig a little deeper and we can identify the source of anxiety, then does it involve people? Does it have anything to do with people? And if it is involving people, then we have some more questions here. Um, when specific people leave, when specific people are present, when any people are present or unknown people are present. And so that's where we have, a difference of this diagnosis. But again, thinking about the context from which we came, and we're looking at a book that has, over 800 pages, and we're trying to identify which page does this person fall on. Stepping back, the first thing that we heard in that interview was that they had anxiety, that they had, some excessive worry, some hypervigilance, some restlessness. We're hearing those key words, and that's what led us to the anxiety portion. And even, on this page itself, we have we have 10 diagnoses on this particular page. But even with these 10 diagnoses, we are able to gather specifics by asking the right questions. So again, the first thing that we asked was medical conditions, or any physiological experiences. Are there heart palpitations? Are they sweating? Are they feeling different when, physically different when this excessive worry is coming about? When these intrusive thoughts are, we want to kind of, break down and for us is closely identify. But again, once, what the hope is to go from so many possibilities to what are factors that can break down, and really get us to where we're trying to end up. So here we have anxiety continued, where is the anxiety related to any of the following, or again, can the stressor be identified? And so we do have specific phobias, animals, natural environment, blood injury, situational. So the possibility is endless. But how does this come, once we ask those questions, how do we document it? What happens next? Well, that's where we as clinicians or counselors, we put together this little statement that, of all the questions that we've asked, we're just going to kind of summarize. So how do we report that anxiety from the questions that we have already asked? So and so here I have client reported excessive worry, agitation, and restlessness. Client displays signs of, and that should be hypervigilance. According to the DSM-5, client meets clinical criteria for general anxiety disorder as evidenced by reports of. And so in this particular case, the reports would be excessive worry, agitation, and restlessness, and observations of the clinician, myself, the counselor, observed hypervigilance. So, so from here, from our initial, we were able to say, okay, we've gotten, from and I just realized, guys, I'm so sorry. We totally went from neurocognitive over to mood disorders. I completely just realized that, so I do apologize. But we are, we're going. Here is pretty much just like a review of some of the sections when we're breaking down that DSM. So again, we heard words of excessive worry, that's anxiety. Then we ask, are there any physiological or medical conditions? Can the source be identified? Is the anxiety or the source of stress related to people, or is it related to something specific? And then after everything that we gathered, this is the result that we came in with. And as we mentioned earlier, if we wanted to go further and we wanted to further defend or support this DSM diagnosis, then we could incorporate the Beck anxiety inventory as additional support, additional evidence, additional information to document our diagnosis. The next thing, the next mood disorder that we're looking at is depression. And with depression, we may ask some questions that are a little different, but we're still looking at the first thing that we hear may be sadness, and may be episodes of isolation. And so it's very once we hear those key words, then we can immediately move into getting more specifics. And here, for depression, we really want to take into consideration the duration. How long has the person been experiencing this? So when we look at anxiety, we're really looking at the source of the stress. Depression, we're really looking at once sadness has been established, what has been the time frame. And so the time frame will push us between the different diagnoses. And so here we have, we do also have this first question. Are the depressive episodes related to medical condition, or do they have physiological experiences? So we do have the depressive disorder related to a medical disorder condition. Then we have the premenstrual dysphoric disorder. Then we have substance-induced depressive disorder. If we see that none of those are present, if there are no medical or physiological experiences within the depressive episodes, then we can move on to the frequency. When the depressive episodes begin, or the onset. Are the depressive episodes present most days? And are there any other excessive emotions or behaviors experienced during this time? If we are, once we obtain the responses to all of these, if we are looking at from 6 months to 2 years with depressive episodes only, then we could be looking at a potential diagnosis of major depressive disorder. It could be other depressive disorder or unspecified depressive disorder. When we are unable to identify, let's say maybe a time frame, or unable to identify the other emotions or other specifics, then that's when we may use an other or unspecified depressive disorder, unspecified anxiety disorder, unspecified psychosis. We can use these unspecified once we identify what the major behavioral concern is, but we cannot provide enough specifics. Then we always have these others, but we have to defend a little bit more when we have an other or an unspecified. However, if we go with the major depressive disorder, and then we support that diagnosis with the Beck depression inventory, then here we have then we have supporting documentation of what we have what we have identified as a potential diagnosis. Now, when we are looking at the depressive disorder, there are uh, earlier, well, just above, we looked at the excessive emotions or behaviors that are experienced. Well, this allows us to provide more classification to the major depressive disorder by identifying the presence of anxiousness, um, a mix of emotions, melancholic behaviors, atypical, mood congruent, catatonia, peripartum, seasonal, and also or if in case there was a loss of life. So we go from the major depressive and we move into a place where we are looking at more specifics. And I feel it's very important with depression. Well, in general, it is is very important with depression to identify if there was a loss of life, because we could be looking at a persistent bereavement, or we could be looking at simple grief, where if somebody is not used to the loss of life or used to losing family, then the stages of grief may appear so different to them, and so in order for and so grief is expected to be present 6 to 12 months. But once we go beyond that, then we may be looking at the potential of a persistent bereavement disorder. So when I think about bipolar, getting back to those initial questions of, how are we breaking down this DSM? Under mood disorders, do we have anxiety? Do we have depression? Or do we have a little bit of both? If we have a little bit of both, then we're looking at a bipolar disorder. Let me get that there. So when we're looking at bipolar disorder, we're looking at an occurrence of manic and depressive episodes, a report of fluctuation in moods, and we really want to look at a 2-week time period to see if these fluctuation of moods, the presence of the manic episodes and depressive episodes are within this shorter time period. So again, here we have some specific questions. First thing is, are these mixed moods related to a medical condition? Are these mixed moods? I'm sorry, guys. I totally lost my train of thought. Are these mixed moods, are they an onset with intoxication, or with withdrawal? Next are when did the mixed moods begin? So we really want to get back to that duration. When was the onset, and how many days, is this occurring? And so when we look at bipolar and we're looking at the manic episode, then we're looking at increased energy, moods, irritability, goal-oriented racing speech, hypomania, at least 4 consecutive days, also of increased energy, irritability, and goal oriented. And then still within that same 2-week period, are we experiencing days of depressed moods or loss of interest? And so again, within the bipolar disorder, then we also still have other factors that can be considered. And thinking back to depression, I would just like to go back really quick, guys. One thing that I did forget to mention. So when we're looking at, once we've identified depression alone, then we're looking at 6 to 2 years. But if we're looking at 2 years or more, then we're looking at persistent depressive disorder. And so if you were to, take a visual in your mind, just to think, anxiety, identify the stressor. Depression, how long has it occurred? Major depressive, less than 2 years. Persistent is over 2 years. But ensure that, this is not the experience of a loss of life that's been less than 12 months. If it's over 12 months, then we may be looking at the bereavement. The reason why I go back to that is because um, as we are looking at the bipolar disorder, and we're looking at, when was the onset, we're really stressing these 2 weeks. But if we have this cycle of moods, this anxiety and depression, 2 week period, anxiety and depression, anxiety and depression. If this cycle continues over 2 years, we're actually looking at cyclothymic disorder. And so when we just like take a step back again, really, really, kind of tossing that big phone book out the window, but just putting in our minds that, what is it that's the primary concern here? Is it a mood disorder? If it is a mood disorder, is it anxiety or is it depression or is it both? And if it's anxiety, what's the source? If it's depression, how long has it been? Well, it could be major depressive, it could be persistent, or previously known as dysthymia. Is grief a concern? Could it be bereavement? And we do have other specific in there, but we can start with with the foundation, just to always have in our minds that these are the things that that we need to look for. So again, cyclothymic disorder is the presence of anxiety and depression over 2 years. But I do, just kind of like try and keep that in mind, that the duration is so important when we're looking at certain disorders. So another thing that's very, very important to note with bipolar disorders is that suicide rates are 15 times more than the general population. And that lack of stability, that those unstable moods and in the fluctuation is so very important, that we want to be sure that we keep that in mind, that when we are seeing those levels that go up and down, that we are assessing appropriately and ensuring that we're asking the right questions to know where is that person, in terms of thoughts of hurting themselves or someone else. So here next we have, how does, after we ask these questions about mood and how long they've been experienced, what is it that we take and we put into writing as data, as reporting the information that's relevant to the diagnosis? So here under report, we have client presented with symptoms of fluctuating and unstable moods, ranging from flight of ideas, irritability, and depressed moods. Client displays signs of inability to focus or respond to inability to focus, or respond to distractions that okay. According to the DSM-5, client meets the clinical criteria for bipolar 1 disorder as evidenced by reports of depressed moods for 1 to 2 days, such as with feelings such as worthlessness, psychomotor agitation, surrounded by episodes of mania, including inflated sense of self, decreased need for sleep, excessive involvement in activities, and observations by clinical staff. Also, that should be also indicated, highly distractible and increased talking. Client reported the onset and journaling of inconsistent moods on February 15th and recalls 2-week cycles of instability. So the reason why I gave that, that particular date was, again, we're really looking at the presence of, of these signs or symptoms, but we're looking at a specific 2-week period, which, makes it so important because, when we have that up and down, then we want to keep that in mind. Also, when we're looking at bipolar 1 versus bipolar 2, a major difference between those two is when we have bipolar 1, we have the mania, hypomania, and then the depressive moods. Bipolar 2 is the absence of the mania, but what we see, it's almost like instead of us going from level 1 I'm sorry, from the ground level to level 1. With bipolar 1, if you would, entertain me for a second, imagine jumping from the bottom floor up to the second floor. It seems very hard to do, but that's kind of what happens when we have bipolar, when we have the presence and signs and symptoms that support bipolar 2 disorder, is the lack of mania. Mania is kind of like that middle step. Hypomania are those extreme ups and downs, ups and downs. And so when we're looking at bipolar 1, well, do we have a mood disorder? Yes. Which mood disorder? Anxiety, depression? Nope, we got both of them. Okay, cool. How long have we been experiencing this? Oh, okay. So we're looking at, 18 months. So we're less than cyclothymia, but we are looking at the presence of the anxiety, depression, the presence of the depression. But then, well, it kind of goes up and down. But when we jump from one really high, down to the depressed moods, then we're looking at bipolar 2. And so I say these things just to kind of give you, something to keep in mind, or keep a concept and a thought to, to easier, to more easily dismantle the DSM itself. So guys, I'm really going to try and, speed up, because I want to, have you guys, have the opportunity to ask questions. But the next thing that we're looking at is stress related. And again, here we are also looking at time frames, and can the stress be identified? For the psychotic disorders, time, very, very, very important for the time. But then, the other features, what are some of their affects? What are some of their facial expressions? And is there a presence of other moods, in fluctuating moods? So as we had just discussed, bipolar, when we look at the presence of psychosis, plus the presence of mood, and if we have the presence of both anxiety and depression, immediately that's schizoaffective, because that is bipolar, depressive. 2 weeks we're looking at for schizoaffective. Schizophreniform is a shorter time period. I'm sorry, not shorter time period, but a few different symptoms from schizophrenia. So schizophrenia, we're really looking at the time frame and the presence of the delusions and the hallucinations. Sorry, I went the wrong way. But once we have the presence of the psychotic signs and symptoms, then do we have the presence of something else? And what is the time frame? What is the duration? Schizoaffective always stands out to me, just because I kind of go from psychosis to mood, and then to have both, is definitely something that stands out. But again, we do want to ask about, again, the medical conditions, and some of the other factors that an individual may experience. So here I just have another disorder that is, in the DSM, is tic disorders. But I offer this to you for you to be able to see that, once you can kind of break down which section of the DSM you may be looking at, then in a lot of times we're going to have a certain population, we're going to see some consistency there. By all means, we're certainly going to have our outliers. We're going to have some that we don't see as often as others. But, in general population, dealing with average clientele, self-referral, then, we may see this consistent population. Dealing with tic disorders, this is something that we may see, closer to a medical or psychiatric type of setup. And then if we're dealing with recurring psychosis, then we may be in a community-based program that incorporates a lot of crisis intervention, crisis prevention. So, once you kind of get to a particular area, then I encourage you guys to look at the population that you support the most, and then create yourself your shortcuts and ideas that that you may want to be able to document. Okay, so I do have a quick question here in the box. Question: is COVID pandemic considered situational when talking about stress, depression, anxiety? It has caused people. I am just not sure how to diagnose since the situational, since the situation means a lot to me short term in the pandemic of this year. So in terms of, sorry guys, in terms of COVID, and I thank you so much for that question. And guys, please do feel free to go ahead and put some comments in the comment box. But I would like to go ahead and address this really quick. And so when we're looking at COVID, I actually read an article not too long ago that was referring to the possible adjustment of acute stress disorder as it relates to COVID-19 and the stress that it brought about. And so at this time, post-traumatic stress is normally looked at as a longer period of time, and an acute stress disorder is a shorter duration. But the questions here are, and that should be, should the trauma, what is the time frame of the trauma, and can it be identified? Well, in this particular case, COVID-19, yes, that trauma can be identified. So how long has it been experienced? Well, as of right now, it would definitely be acute stress disorder, because it has now reached a 2-year time frame. But I would, encourage you guys to be on the lookout, for changes to stress disorders as well as depressive disorders, because our levels of depression have increased in general population with so many people being isolated, and so I do think that is important to note. So to your question, sir, in terms of COVID-19, I would definitely look at the acute stress disorder or other unspecified, and then when you go to specify, then you include the specificity. I'm sorry. Include the specific factors as it relates to COVID-19, which does include isolation, which does include, the presence of anxiety, in extended periods of isolation. We don't want to use the word forced isolation, but pandemic influenced isolation. Also identifying, that as being, a source of stress. Mm-hmm. Oh, and I'm sorry, Jamie. Yes, I see. I'm sorry if you are a lady. My apologies. Um, and so I do think that your question, Miss Jamie, is extremely important. And then with the pandemic, also looking at bereavement and grief. So we do want to be able to put there that it could be acute stress disorder, or it could be stress disorder unspecified, with the presence of grief, in addition to influence or pandemic forced isolation. It could be it could also be other stressors that created concern. It can be the distance between family, the lack of communication. It could be inability to access previous physician or to get appropriate care as it relates to other specific areas. So when we have unspecific or identified, we really want to take the time to include those, include any specific circumstances that have contributed to that stress. And there is no limit that we can incorporate here in that particular section, because we have the opportunity to provide a clinical impression, which is all of the things that we as the clinician deem to be important. So on this page, really quick, guys, I know we got to wrap up, but we have the substance-related disorder. And so the substance-related disorder is going to be consistent for all of the substances. So if this person, if their substance of choice is going to be alcohol. Then it's going to be that alcohol is taken often in larger amounts and over long periods of time, and so on and so forth. So it would be the same for stimulants, the same for anxiolytics. It'll be the same for cannabis. So again, how do we support? We want to support by completing additional inventories and want to document those. And the mental status exam, we definitely want to gather that information. So I'm going to stop here so I can give you guys a minute to ask any additional questions. But I do certainly know that that Miss Colleen will be able to send out the remainder of this PowerPoint for you. And I do highly recommend that you look at it because it will include some more details in terms of diagnosing and how to take it from the interview questions to implementing into actual practice.
All right, thank you, Jessica. That was a great presentation. I'm gonna go ahead for everyone and share the CE questions in the chat that you can answer to. And at the same time, feel free to write any questions for Jessica or raise your hand with that option, and I'll try to facilitate this process for Jessica as well. So I'm gonna go ahead and start posting them inside. You can go ahead and answer and ask any questions if needed as well. Do you see my questions? I don't see them going through. Just a moment.
I don't see any questions on my end either, Malik.
Okay, just a moment. Well, feel free to ask questions. I'll try to get the CEs in. And yeah.
Okay. All right. Well, guys, I definitely hope that this experience was somewhat helpful to you in the process of writing your assessments, clinical assessments, and clinical interviews. I probably got through about half of the presentation, so I do encourage that you do look through the rest of those slides. I do think that it may be helpful, and if not helpful for you right now, then maybe it'll be helpful for you in a few years. Oh, we have a question.
And they are 5 questions.
Mm-hmm.
So I'm just typing them in really quick.
Okay.
I think it's the word count. It's not letting me post it all in.
Gotcha.
You can be patient with me. Okay.
Jessica, this was very helpful. As you know, I struggle with documentation. And really kind of conceptualizing which of the diagnosis does this person fall under based on time frame or event, when the event started versus what, now what he or she's reporting today. So this was very helpful. Thank you. I'm so glad that I found your I'm about to say TikTok.
The link.
Thank you.
Oh boy. Yes, it is. But we got to find a way to make it easier for each other. So I'm gonna make sure that you have it available, and make sure that anybody can use it if they like.
I will also echo. Oh yeah, go ahead. Sorry.
No, I just seen Sheena's question. So Sheena, I do believe that the video will be able to be obtained, and yes, it is a lot of information. But you can, but I know that you should have access to the PowerPoint at the close of the CE distribution. If by chance you don't, then definitely please reach out to Miss Colleen if you do not receive access to the entire PowerPoint. And I'll be more than happy to, she'll be more than happy to make sure that you do get a copy of it. And I'm glad that it was helpful to you. So, That just makes it all worth it. Helpful to you, helpful to Shawnee. Malik, were you about to ask a question?
Uh, I wasn't gonna. I just want to answer. Let's see, Sheena, really quick, and say that and to everyone, if anyone has, like Jessica just said, reach out to Colleen for the information. They're supposed to post it out. But I just want to echo what Shawnee was saying, and similar to Shawnee, I have a hard time diagnosing, but I feel like because we kind of discussed depression during our supervision. But this, you're opening it to the other realms of the DSM, and I think it's a very systematic way to and logical step-by-step way to kind of filter things out. And I really appreciate that, and I will definitely be looking for this presentation,
I'm
and maybe
glad.
marking this down as supervision.
Oh, that too. That too is a lot of information. Hey.
Thank you, Jessica. That was great.
Thank you. Thank you, guys. Y'all have a great one, okay? Oh, Shawnee, got a question?
One question.
Sure.
Maybe somebody can answer it in the room. If we're graduating this year, do we need CE credit? Should I be
No,
at?
but if you hold on to them, you can use them. Most boards will accept them for 3 to 5 years.
Oh,
Okay.
wow.
All
Yeah.
right.
I
That's
think I just got finished with all of mine from like um 2013.
wow.
Yeah.
Okay.
Hold on to them. Every bit of documentation, hold on to it tight.
Wow.
Thank you.